My name is Lydia Pecker, and I'm going to talk to you about taking the best care of girls and women with sickle cell disease. We expect that girls with sickle cell disease will live well into their reproductive years and beyond. They need care that attends to their medical, developmental, and social needs. This is a talk about what you need to know to take the best care of girls and women with sickle cell disease. Playing sports is good for growing, learning, and self-esteem. Girls may not play sports because their parents worry about complications of sickle cell disease. Encourage hydration and full participation in sports. Puberty is delayed in girls with sickle cell disease. Genotype, treatment choices, and family history likely affect this trajectory. And remember that being a late bloomer can have social consequences. Talking with parents and children about expectations for normal development is important. Menstruation can cause sickle and non-sickle pain in our patients, and the patients can tell you the difference. This pain is associated with lower health-related quality of life, and contraception may help control periods. Contraception can prevent not only pain and heavy periods, but also unwanted pregnancy in women with sickle cell disease. Consider sickle cell comorbidities like stroke, headache, and blood clots when you are advising women. Remember that sickle cell disease is a thrombophilic state, and so contraception that contains no estrogen is preferred. If you feel uncomfortable counseling patients about choices for contraception, refer them to a doctor who can. It's good to communicate with the other doctors about sickle cell specific risks associated with contraception, especially risks related to clots. If you don't have enough time to help your patients decide, you can use decision aids available at bedsider.org or Planned Parenthood. Women with sickle cell disease have heard that they can't get pregnant. You should tell them women with sickle cell can become pregnant, that we don't know if women with sickle cell disease have infertility, and that the definition of infertility depends on whether you are 35 years of age, younger, or older. Many sickle cell disease related variables may contribute to changes in reproductive lifespan for women with sickle cell disease. This includes treatment choices, disease complications, and other kinds of family history. Girls and women with sickle cell disease may bank ovarian tissue, eggs, or embryos, especially before transplant or gene therapy. This requires complex care, and they may need transfusion, intensive spirometry, anticoagulation, and monitoring for ovarian hyperstimulation syndrome. Resolve.org is a great resource. Women with sickle cell disease are told their children will have sickle. Offer genetic counseling for them, and explain and obtain hemoglobinopathy testing for their partners. Provide preconception counseling. There are many ways to become a parent and make a family. For women with sickle cell disease, having a baby at risk for having a baby with sickle cell disease, there are many options, including prenatal diagnosis with IVF, pre-implantation genetic testing, using a donor egg and sperm, and many other choices. Women with sickle cell disease have heard that pregnancy could kill them. Maternal morbidity and mortality is increased in sickle cell disease, and pregnancy is complicated. There are also risks to the fetus. Providing great prenatal care means collaborating with a high-risk obstetrician, change treatment for patients with severe disease, stop hydroxyurea because it is a potential teratogen, stop hydroxyurea 3 months before conception if at all possible, and if not, it is often stopped at the diagnosis of pregnancy. You may also want to consider monthly exchange transfusions, as this is an intervention that reduces complications in the mother, even though the effects on the fetus are unclear. Think about all kinds of end organ injury for women who are pregnant, including the lungs, the kidneys, and the eyes. Think about transfusion needs and risks for alloimmunization. Think about which medications you need to stop, including chelation. Think about risks for infection and which vaccines your patients need, either during pregnancy or before. C-sections are common, especially in women with hip disease. Provide incentive spirometry, monitor infants for neonatal abstinence syndrome. At present, taking hydroxyurea is contraindicated to breastfeeding. Other issues for women include weight and bone health. Nutrition clearly influences bone health in women with sickle cell disease, and obesity is an emerging problem. It is reasonable to measure vitamin D and offer replacement therapy as indicated. Older women with sickle cell disease may go through menopause. If estrogen is needed, transdermal estrogen is less thrombogenic. Evaluate these patients for fall risks, including their opioid use. Encourage adherence to regular medical care and assess social supports and risks for social isolation. Remember, sex and gender are not the same. Some people with sickle cell disease may be transgender. Hormone therapy is complicated in these patients, but should be offered. Encourage patients to use disease-modifying therapy and help reduce their risks for clots. Girls and women with sickle cell disease have sex and gender specific needs that you can manage. Thoughtful care across the lifespan empowers women, transforms outcomes, and changes lives. You can do it.